And one of the difficult things about treating women with endometriosis is that some treatments may be effective for some women and not effective for other women.
There's a lot of myths and misconceptions around endometriosis.
For example, endometriosis doesn't occur in teenage children. Well, it certainly does.
Endometriosis has been diagnosed in girls as young as 8. It can occur before puberty begins, and women in their teenage years, as they hit adolescence, can start to suffer and have very severe endometriosis.
Another misconception is that it will be cured by pregnancy. That's totally erroneous. Pregnancy will suppress the symptoms, but the disease will still be there and the symptoms will recur typically about 12 months after the pregnancy.
Some of the other problems and myths associated with endometriosis is that a single treatment will cure it. Although you can remove lesions surgically or you may make them regress, they can still come back, and recurrence of endometriosis, even with optimal treatments, can be in the range of 50%.
It is true that for some women with severe endometriosis, a hysterectomy does form part of their treatment, but that's relatively rare. This is disease growing outside of the uterus, so the disease itself needs to be removed, and it is usually possible to be conservative with respect to the uterus.
In the area of medicines, we use either anti-inflammatory medications or painkillers. We can use nerve-modifying medications to change the way that pain is perceived, and we can use hormonal treatments as well to directly affect endometriosis lesions.
The oral contraceptive pill is probably one of the most common types of hormone that we would use for women with endometriosis.
And certainly there are situations where women use acupuncture and natural therapies, and they seem to be incredibly effective. Whilst we don't have very hardcore scientific data as yet, there are a number of studies around the world that are looking at these areas, and they really show some very good initial outcomes. I don't think we should exclude these treatments, and as a Western practitioner, we need to embrace all kinds of different treatments that allow women to get on with their everyday life. So, if women are having acupuncture or using natural therapies to assist and they're finding them very useful, I always encourage them to continue to do so. So once we've made a plan to have a surgery to investigate and treat endometriosis, generally that means having a laparoscopy.
There is a range of different surgical techniques which are performed at the time of laparoscopy to remove endometriosis. The two main groups are excisional techniques and ablation techniques. And an excisional technique is where we actually remove or resect all of the abnormal diseased tissue to get back to normal tissue underneath, whereas an ablation technique uses heat or another energy source to effectively burn or destroy the disease from the surface. So one of the benefits of excisional surgery is that we can perform a diagnosis and send it off for pathological specimen in the lab, which also helps with that official diagnosis of endometriosis.
The important thing is not how you get it out. The important thing is that you do take all of it out. And if you think of the endometriosis lesions as being a tree, if you burn them, sometimes you only get the leaves, sometimes the branches, but you may not get the trunk or the roots. And we often prefer to use a cutting technique where you can take the top to the bottom, including the roots, and get the whole of the lesion out. This is what we consider a minimal access technique. What that means is a woman would have a general anaesthetic. We then make a little incision inside the belly button and we put a camera into that area, and then we use up to 3 other puncture sites, sometimes fewer, sometimes more, to put in long instruments. And those instruments help to move organs out of the way and allow us to put in other instruments such as scissors to remove the endometriosis lesions. Once the instruments are put into the abdomen, we have a look from top to bottom. So all the way up from the diaphragms, that's the area directly under the lungs, the liver, the outside of the bowel. We can see all the way down to the lining of the pelvis, the uterus, the tubes, the ovaries, and around the bladder. And these are the commonest areas for endometriosis to occur. What we can then see is where the lesions are, and we make a plan to remove all of those lesions. This whole process can take as little as 30 minutes, but it may take several hours, particularly if the endometriosis is severe. And that can mean that the woman needs to stay in hospital for just a few hours and sometimes several days. This is fairly extensive and sometimes critical surgery, and it's not without risks.
Just because a woman has endometriosis present doesn't mean that you need to rush in and take it out. And I have quite a lot of patients who have severe bowel endometriosis, but while they do have some symptoms, their symptoms just don't justify going through that degree of complex surgery.
Whilst we try and always minimise the risks to the woman, these are not always possible, and sometimes we have to balance out leaving some of the disease behind, particularly if it's in the back of the uterus, around the cervix or close to the ovary, because to remove it would mean removing these organs and mean that she couldn't have babies in the future. One of the most important things about surgery is to make sure that your surgeon is an experienced endometriosis practitioner. That sometimes means liaising with other specialists in other areas, such as urologists who work with the kidney, the ureters and the bladder, and sometimes with bowel specialists where we need to remove lesions from these organs as well. It's this team approach where you are in surgery that makes sure that we can optimise outcomes for women and get the very best for her care. It's estimated that for infertile couples, about 40% of women will have endometriosis. I'm often asked about how to become pregnant if you have endometriosis, and the answer is actually relatively simple because there's only 3 ways. You either keep trying naturally, and hopefully the numbers will eventually stack up in your favour, because endometriosis doesn't always prevent you from becoming pregnant. It's just associated with subfertility in many situations. The second way would be surgery, and there's good evidence to show that removal of endometriosis lesions will double the chances of pregnancy, and we've now got some very good studies to indicate that even in very severe disease, removal of endometriosis can improve your chances of becoming pregnant naturally. And the only other option is assisted reproductive technologies, and I use this as kind of a wide-ranging diagnostic basket. So it's not just about IVF, there's a whole range of treatments in that group where you may need some assistance to become pregnant as a couple.